Hi, I'm Danielle Wilkes, and my presentation is on meconium aspiration syndrome. So I'm going to start out with telling you what is meconium. It is known as the first stool of the newborn, and it's composed of mucopolysaccharides, cholesterol, bile acids, and intestinal enzymes. And it's usually excreted around 24 to 48 hours after birth, and it's darkish green in color. But it oftentimes will be released while the fetus is still in utero because the fetus has gone post-term, and this is usually going to occur around 41 or 42 weeks of gestation. Now, this can become a problem when it's excreted into the amniotic fluid, and something called meconium aspiration can occur, and this will occur in some term fetuses, also post-term or stressed fetuses. And it is also a common issue in fetuses with oligohydramnios. And what happens is the meconium, like I said, is excreted into the amniotic fluid, and then it is aspirated into the lungs by the fetus. The effects of meconium aspiration. It can lead to meconium aspiration syndrome in 5 to 10% of pregnancies, and in those 5 to 10% of pregnancies, there's a 4% mortality rate. This meconium aspiration can cause obstruction in the lungs, lung tissue damage, and pulmonary hypertension. Clinical indications that meconium aspiration has occurred. During labor, there will be cardiac decelerations, tachycardia of the fetus, and the amniotic fluid will be stained a darkish green color, and then this will also occur in most post-term deliveries. After delivery, postpartum, the infant will be cyanotic, tachycardic. APGAR score will probably be less than 5. There will be an acidotic umbilical artery pH, and whenever you realize that the infant has possibly aspirated meconium, you will suction the airways and you will find meconium in that suction. The baby might be retracting and grunting, and there will be an abnormal chest x-ray showing consolidation, and then also auscultation will show coarse crackles. The treatment depends on the severity. If you have a vigorous infant, meaning that their heart rate is at least 100 beats per minute and they're breathing well and they aren't cyanotic or anything like that, they have good color, then that's considered a vigorous infant, and all you really need to do is suction the mouth and then the nose, and you can just do that with just a suction catheter, and then you can also provide supplemental oxygen if necessary. A non-vigorous infant, you'll intubate with an ET tube and then suction, and you'll repeatedly suction until you no longer have meconium in the aspiration. Oftentimes, if the baby is still not vigorous and they're having issues ventilating, you will keep the infant intubated and will do mechanical ventilation. You can also do surfactant administration since you have suctioned them so often. And a lot of infants don't need to remain intubated, it just depends on the severity. Prevention of this. In infants that have oligohydramnios, it is kind of common to do something called amnio infusion, where you infuse more fluid into, sorry, my dog's whining at the door if you hear that. So you infuse more fluid into the amniotic fluid, and so that kind of dilutes that meconium aspiration, and it's kind of controversial if it helps at all, but it is sometimes done. The most effective way to avoid meconium aspiration syndrome is to avoid allowing the pregnancy to go post-term, because the meconium more than likely will not be excreted unless the fetus has been allowed to go post-term. And then also, if the fetus enters fetal distress, you need to quickly have that fetus delivered to avoid aspiration. So those are my references, and that is my presentation. Thank you.